Hello. Welcome to RSSDI Diabetes Bytes. At the outset itself, it gives me immense pleasure to share with you all that our viewership of RSSDI Diabetes Bytes has gone up by 67%. और ये सब इसीलिए मुमकिन हुआ है क्योंकि आप सब ने इस प्रोग्राम को बहुत सराहा है। आपके लाइक्स, कमेंट्स, शेयर्स और हमें बहुत प्रोत्साहित करते हैं कि हम और भी अच्छे प्रोग्राम्स आपके लिए प्रस्तुत करें हर हफ्ता। और हाल ही में आप सब जानते हैं कि आरएसएसडीआई ने अपनी सुनहरी वर्षगांठ या सालगिरह मनाई बहुत शान से नई दिल्ली के ऐतिहासिक एम्स हॉस्पिटल में। और बहुत सारी अच्छी दिशाओं में हमारे इनिशिएटिव्स शुरू हुए हैं, तो एक के बाद एक हम आपके साथ शेयर जरूर करेंगे। So 50 glorious years of RSSDI, 50 glorious years of treating, understanding, and preventing diabetes in India. And today it's an absolute honor for me to have three eminent experts from the Indian soil of international repute with us. We have Professor Dr. Vinod Kumar, sir. Welcome, sir. He's from AIMS itself and our RSSDI patron. He has seen RSSDI right from its inception. We have also with us Professor Dr. Sarita Bajaj, ma'am, who is the first woman president of RSSDI. Welcome, ma'am. She's an head endocrinology from the city of Prayagraj, and it's an absolute honor to have you, ma'am. And if you recall, the very first episode of RSSDI Diabetes Bytes was also with you.
Oh, really? Good. Very good.
Yeah. Yes, sir. And we have none other than our very senior and very, a father figure to RSSDI, Professor Dr. Ashok Das, sir, who is a senior head of department endocrinology from Puducherry, and he's our patron as well. And his memory is very sharp, and he's an astute clinician, and he remembers RSSDI over the years like no one else does. So, without much ado, today we are going to talk about the evolution of diabetes treatment in the last 50 years. And may I hand over to Professor Dr. Ashok Das, sir.
Gurbi, thank you very much. And under your stewardship, Diabetes Bytes has grown from strength to strength. And today we have discussed some other issues also on the organization, and you will see the manifestation in the next meeting. Dear friends, this is a unique meeting, and I have great pleasure in inviting you, the large number of audience, both the doctors and the general public who have joined for this meeting. Dear friends, you know, an organization is as good as its history. And RSSA today is the 50 years young. And on this 50th year, we thought it absolutely important that we ask the senior members, senior fellows of RSSDI, those who have given toiled hard, worked with the founders, from both Professor Vinod Kumar and Sarita Bajaj, Dr. Sarita Bajaj, Professor Sarita Bajaj, have been these. I mean, Dr. Vinod Kumar had been the close associate, and Professor Sarita Bajaj had been the students of Professor Ms. Ahuja, the founder of RSSDI, and has seen the entire 50 years. Dear friends, we have one constraint that I have been given 30 minutes, will be 30 minutes from now. So we have got about 6 sections. So I'll be asking questions which are very brief. I will also request my senior members to kindly answer briefly so that we can take all the questions. With that understanding, can I ask? We have got 6 sections. So each section is 5 minutes. The first section is about the perception of diabetes. My first ask Professor Vinod Kumar. Uh, I think I need not introduce him. Who is the living legend of RSSDI, close confidant of Professor MMS Ahuja, the professor and head of endocrinology at the famous PGI, and the senior faculty member at the AIMS, and contributed immensely for the SDI. Going in a scooter, getting registered. I have no time to narrate all that today, but I must tell you, sir, we are delighted you are here with us. So first few questions are on the perception. Sir, what was the perception regarding diabetes as a health issue in our country 50 years ago?
Thank you, Professor Das,
Just
for
call me Ashok, sir. Just call me Ashok. Yes, sir.
okay. Thank you, Ashok, and thank you for inviting me to such a wonderful program where we trace back the roots of diabetes, at least 50-year-old roots in this program, and what we were at that time and what we are today, having grown, as you said, from strength to strength. With regard to the perception of diabetes, about half a century ago, when RSSDI was born, I would like to mention that diabetes was a relatively uncommon disease compared to what it is now. The prevalence of diabetes in this country, including both rural and urban areas, was only to the tune of 1 to 2%, and now it is almost 10 times. And in the elderly, today, I think 1 in 4 or 1 in 5 persons is a diabetic in our country. That is the scenario about the diabetes as it has evolved over the last 50 years. At that time, half a century ago, was sitting on a back seat. Public and the government were more grappling with the problems of infectious diseases like tuberculosis, malaria, smallpox, and so many other easily infection diseases, and of course with child and mother health. People were not obese at that time. They were not very sensitive to diet control or exercise. So that was the situation of diabetes at that time. Today we are in a completely different era, as you would narrate during the
Absolutely.
episode. Thank you.
Sir, I think I remember a joke, sir. When I became additional DGHS, they told me you cannot enter the DGHS office. I said, why? You said you have to be pregnant. I said, what is this? He said, today the DGHS focus is on the maternity child health, as you rightly described that. And now the focus is on NCDs. So I think you have beautiful narrated. I will not repeat it for the interest of time. But I just want to ask a very pointed questions to Madam from Sarita Bajaj, who, sir, in a recent meeting, it is our own meeting. We all called Farida Madam as the queen of endocrinology of the country. So I mean there's an unofficial meeting, but I must tell you there is the respect, love she commands amongst all of us. Madam, I just wanted to
Thank you.
ask you, uh, how has our understanding about diet evolved in last 50 years? Madam, I'm acutely concerned. Next meeting, Purvi told me will be on diet. So very brief, in a minute or 1 minute and a half. Understanding of diet evolved.
Thank you for the question. Thank you to RSSDI for the invitation and congratulations. I think the language should be more of English. I think पूर्वी भी
इंग्लिश
हिंदी
हिंदी
में बोल रही
मैडम कंबाइन कंबाइन मैडम इट टॉक शो सो कंबाइन आप तो हिंदी में आपका तो
या
जवाब नहीं मैडम
पूर्वी ने तो बहुत अच्छे से बाग डोगरा संभाली हुई है डायबिटीज बाइट्स की and the credit of the increase in viewership 67% I think goes a lot to Purvi. She's extremely hardworking and so many episodes have gone down. So like you said, जो खान पान के बारे में है, at least as far as Uttar Pradesh is concerned, let me at least tell you about my state first. It hasn't changed, or at least over the last 4 decades since I've been in sort of a post MD. Because I mean, it's just those 3 words: parhez, chini, चावल और आलू. घूम फिर के उसी पे अटक जाती है कहानी.
ब्यूटीफुली सेड
बस
चीनी चावल
चीनी,
एंड आलू
चावल और आलू हमेशा. I mean, like आज भी. I mean, if I go back 4 decades and I see now, it's chini, chawal, and aloo. But we are aware of the fact. See, recently, today, Dr. Mohan has shared his article on macronutrients, which has been from the ICMR in diet study, of which I was a part. The basic principle of diet management has still not changed. I remember when I used to teach about, say, maybe 3 decades back, the first slide on diet I used to show was from King's College, London. उसमें क्लियरली वो 3 चीजें थी. ये आप बिल्कुल नहीं खा सकते, ये मॉडरेशन में ले सकते हैं, और ये फ्री, सो कॉल्ड फ्री फूड्स. आज भी वही लागू है. Despite your Atkins diet, despite your very low calorie diet, despite your ketogenic diet, despite your intermittent fasting, and there's so many fad diets these days which are being spoken about, and I think more will be discussed, like you said, next week. But the basic concept still remains the same. Your calorie
Yeah.
content and carbohydrate. See, the starch study which we did with Shashank's group, that was about a decade back. I think we're planning to redo it again. It showed that across the country, हम लोग बहुत ज्यादा कार्बोहाइड्रेट खाते हैं, चाहे नॉर्थ साउथ ईस्ट वेस्ट. तो हमें कार्बोहाइड्रेट बेसिकली कम करना है, कैलोरीज का ध्यान रखना है, और मीठा नहीं लेना. सीधी सी बात. खान पान के बारे में,
Very, very prophetic answer, madam.
के बारे में तो बता ही दिया है कि वो नहीं बदलता है. मरीज को हम बोलते हैं भैया चावल खा लो, तो कहता हमको खाने नहीं देते, प्लेट हमारे सामने से छीन लेते हैं. So it's like those, sad stories about the concept of diet still being
High
not
carbohydrate.
properly.
But madam, as you rightly said, may I would like to put little bit of science. What is going around? You are the queen of the science. Your paper, the paper you cited, I am a co-author. We have shown 5% reduction in the carbohydrates, sir. It is published in Diabetes Care. So how
Yes,
5% less can produce great results and change the destiny of the country, madam? I must tell you that there is a little bit of probably change of perception in some parts of the country. In the south, they now think about fiber. They're not exactly high carbohydrate, high fiber diet, but they think about fiber. They say that carbohydrate to go away from the refined carbohydrate to the complex carbohydrate. This thing has happened.
right.
Number two,
And I think they have special rice also now.
yes,
They
they
have
have to
low glycemic index rice.
absolutely. So
So,
that is very
yeah,
important. तो मैं
yeah,
ये बताना
very.
चाहूंगा कि हमारा जो आज आज का जो एपिसोड है about diet will what we I'll summarize what madam said. The diet is the cornerstone possibly for the production of diabetes and a big cornerstone for the managing diabetes. We are what we eat. And इसीलिए a balanced diet of less calories, appropriate carbohydrate, protein and trace elements जो मिलता है. So that is what we need. But having said that, I will hasten to add that there is a little perceived change in the adults. Maybe children are taking a lot of ghee, a lot of fast food, things like that. But one thing I must allude to, Urvi and my senior doctors here, that I learned one thing in a conference in Denmark. If you eat less, you live longer. I'll repeat again. If you eat less, you live longer. So I mean ये मैसेज देना चाहूंगा कि that was madam said that हमारा कैलोरी कम करना है, जितना जरूरत है खाएंगे, उसके ऊपर नहीं खाएंगे. And about the perception of diabetes, जैसे प्रोफेसर विनोद कुमार the father, the living legend said that ये हमारा अभी जो पहले था, अभी we know it as a most important non-communicable disease. You are in the train, you are in the flight, to your right, to your left, there is a diabetic. What time the first study which are alluded to by O.P. Gupta and BBT and Professor Vinod Kumar, Professor Ahuja, the prevalence of diabetes is 2%. Absolutely correct, sir. 1% in the village, 2% in the rural area. And today in the ICU India, as you rightly said, 10 times. So it's a great study. Sir, I would like to ask you.
I
one
just
of the-
like to add, I would just like
Yeah,
to add to that about what the prevalence is. It's so much more common in children now. So we are
yeah.
seeing teens, we are seeing like the first decade. We are talking of type 2 diabetes
I think
in younger ages.
it's a great message that madam has given. Previously type 1 डायबिटीज दैट इज जो जो बच्चे को इंसुलिन जरूरत होता है बचने के लिए लाइफ के लिए ये होता था. अभी बिकॉज ऑफ दिस ओवर ईटिंग एंड द ओबेसिटी एंड जो वो
Yes,
एक्सरसाइज नहीं
so
करना है उसको बोलते हैं सेडेंटरिज्म. द टाइप 2 डायबिटीज इन चिल्ड्रन has poised to become a great issue, and they have also termed it malignant diabetes in the childhood because they have all sorts of complications. And we have a YDR Young Diabetes Registry, and which I chair. I must tell you that it's a great issue which Madam highlighted. Sir, I
we
have
are
one
the
other question.
twin obesity and diabetes.
Yeah,
We are
obesity
battling
and we
both.
call it diabetes, and in children it is playing havoc. Sir, I have one question for you, Professor Vinod Kumar, sir, which is very important. No, sir, what were the aims, objectives of treating diabetes 50 years back, and what are the objectives now?
Well, very good question, because very few will know what were the aims of treating diabetes 50 years before.
Exactly, sir.
I think, as I said earlier, diabetes was not a prominent disease. People were not scared of diabetes, and the aim of treatment was either by pharmacological or non-pharmacological method was simply to keep the urine free of sugar. That is number one. Number two, to keep the blood sugar also under control, but they were not aware that the tight control is important. They were not aware that a very good blood sugar control would prevent the vascular complications. The ordinary diabetic patient 50 years before was more concerned about treating his diabetes and controlling the disease at a loose end, just because so that he doesn't get tuberculosis, he doesn't get any easily intractable infection, and he has a little good quality of life. He was not very much convinced, and neither he practiced the exercise, the kind of exercise that we are practicing these days. They were not exercising. They were not overweight. They were simply no gyms at that time. But now, over the years, we have come to know that the primary aim of diabetes is not simply to keep the blood sugar controlled very nicely, but also to prevent the sinister vascular complications and lead a long life. So the entire thinking about the objectives of diabetes treatment have changed over the years. We have become wiser, and therefore the aims are now different. Thank you.
Very revealing answer, sir. I will not repeat it. To make a long story short, today's treatment of diabetes is holistic. We call integral management of complications, everything. But that time, as you heard from the horse's mouth, it was just taking care of sugar. That too tested. We'll come back to the testing little later. And the complete diagnosis, the complete management, preventing complications was not in the arena, which in the center stage of diabetes management today.
I
Madam, I
will,
have a
I
very
will just, I will
yes,
just add one point.
yes,
I
sir.
was I was taking around a foreign visitor on the ward round one of the days, maybe 40 or 45 years before, and I showed him a patient, adult patient, who was having a blood sugar of 270 or 250. And I asked him that we have tried these kinds of tablets and all that, but his blood sugars are not coming down. He told me, is he passing any sugar in the urine? I said no. Has he got any symptoms? I said no. Then why you are worried about bringing down his blood sugar? Because at that time people thought that bringing down blood sugar in completely normal physiological range was not very not a panacea for preventing vascular complications. People were simply not aware of the vascular complications, that the magnitude of them, which is today, it is enormous attitude, enormous magnitude at this time. So this was the attitude of even diabetologists from abroad.
I think it is very important to remember
Yeah.
that today we are centered
Mhm.
around the number 100. I'm just telling it for simple purpose, not 100. But I'm telling to make it simple. We want to maintain mean blood sugar 100, mean blood pressure 100, and the 100 is the one which is like therefore and postprandial 140. So we were not that time that conscious about the numbers. I think, sir, two trials, sir and madam. One is the disease trial in the type 1, but confining to type 2, it was the UK PDS, which kept the fast concept that controlling blood sugar is the answer to prevent complications. Madam, I have a very important question for you. That time we only have two drugs, madam. The metformin and the sulfonylureas, and of course some insulin. Insulin we'll discuss later. And now, madam, what was your take? That do you think that time managing diabetes with sulfonylurea and biguanides uh, was much better than multiple drugs that we have today, multiple oral drugs that we have today? We have availability plethora of drugs, many drugs in the armamentarium. How it was then, how it is now? Madam, very brief answer.
Okay. So just to go back to what Dr. Vinod said just now regarding the urine sugar. अगर हम आज की तारीख में बोलें कि हमको यूरिन शुगर कंट्रोल करनी है तो that is absolutely irrelevant, especially in the light of the SGLT2 inhibitors. Because you see, when they come back with the urine reports, उसमें शुगर ही शुगर भरी रहती है, तो they are in a panic mode कि क्या हो रहा है, मेरी तो शुगर कंट्रोल में नहीं है, यूरिन में शुगर आई चली जा रही है. So I mean, I'm sort of trying to set the stage for the drugs that are available today. देखिए, इंसुलिन तो 100 साल उसने पूरे कर लिए हैं, और ये हमें पता है कि जब इंसुलिन नहीं थी तो डायबिटिक्स केवल like I mean, it doesn't sound very nice to say that, वो मौत की इंतजार करते थे क्योंकि कोई ट्रीटमेंट नहीं था. लगभग आधी सेंचुरी से आपने कहा 2 दवाएं थी हमारे पास, एक बाइगोनाइड्स और सल्फोनिलुरियाज. उसके बाद से now the market is flooded with not one, not two, not three, not four, but at least half a dozen more drugs. All of it. So हम लोग पहले क्या बात करते थे? Pancreas, action at the pancreas, the liver, muscle, right, and the fat. Skeletal tissue, fat. बस यहीं पे हमारे target थे. Now we talk of the ominous octet, maybe dirty dozen. Does it go beyond that? तो ये दवाओं की जो जैसे आपने कहा आर्मामेंटेरियम बढ़ गया है. हर दवा की अपनी जगह है क्योंकि mechanism of action is different for different agents. Some have one target only. Of if we talk of the ominous octet only, some of them are only acting at one particular site. Some are acting at multiple sites. So we have a lot of good oral agents to choose from today to benefit the patient.
My point
to
is, where you
control the
achieving,
blood
madam, where you achieving control with these two drugs, chlorpropamide and metformin?
तो क्लोरप्रोमामाइड तो जमाना भर हो गया यूज किए हुए, but it was one of the most potent oral anti-diabetic agents. And when we talk of hypoglycemia with SU, this one was at least 72 hours, if not a week or 9 or 10 days. So severe hypoglycemia. Obviously, tolbutamide is no longer there.
No.
Chlorpropamide is no longer there. I think all of us have had the opportunity to use those DBI. You remember DBI TD?
Yes,
Fenformin.
Fenformin, isn't it? और उसका जो nickname था, don't bother insulin. DBI का जो मतलब जो acronym बनाया हुआ था, don't bother insulin. मतलब जब आप ये देंगे तो इंसुलिन से बचे रहेंगे. So this was just in a lighter vein telling you about that. तो हाँ, बहुत तरक्की हुई है, लेकिन मेरा बस एक कंसर्न है. पेशेंट्स की जो शुगर है वो काफी हद तक उसके ऊपर निर्भर है. वो कितना परहेज कर लेते हैं, कितना दवा कोई भी हो, ये दो चीजें नहीं हटती हैं. डाइट, दैट इज लाइफस्टाइल, एंड देन द ड्रग्स. तो उसी में ऊपर नीचे होता है, तो शुगर फिर ऊपर नीचे भागती है, फिर वो दवा ये चेंज करो, ऐड करो, कॉम्बिनेशन, परम्यूटेशन. सो एट द एंड ऑफ द डे द क्वेश्चन again to you, both of you, or to, I mean, across board, is the blood glucose better controlled, which should translate to lesser complications, more patient-centric approach. It's not glucose-centric, it's complication-centric, it's patient-centric. So the whole concept has changed entirely.
Yeah, thank you, madam. Thank you very much. You have rightly said like that, we have got now 12 minutes left. So, but I'll take half a minute to tell a story. There was one sage was walking across the streets of Delhi. There were some road urchins. They were making fun of him, and he came and asked, "Where is the post office?" The urchins answered, "You are giving a lecture this evening. The way to God, you don't know way to post office." In the evening to the meeting, these boys came. He did a small thing in their hand, and they asked the guru, "Can you tell us what is in our hands? Then we'll know that you have some spiritual power." The Lord said, the guru said that it is a thing you have hid in your hand. Either you can give it life or you can kill it. That's what I learned from Sarita Bajaj's lecture. I mean, point that it is also entirely in the hands of the patient to take care. You can either make it, and you know what it was? It was a small, tiny bird with the road urchins could have crossed it or made it fly. So it is exactly that point you have given. So I would like the people of audience today, आपकी सेहत आपके हाथ में है. तो आपका, you are the center of the management. You are the fulcrum around which all revolves. Either you can make it or you can break it. So in another 11 minutes left now, I'll be very quick, sir. I just want to know, sir, Vinod Kumar, sir, very two sentences. How was the monitoring of diabetes those days? Monitoring. You said about urine, but something more about monitoring, sir.
Yeah, Ashok, I would like to thank you profusely for sending your message so strongly. आपका स्वास्थ्य आपके हाथ. This is the buzzword, and if the patient understands this, then he is going to be in very good hands for his health. Now, coming to your question, monitoring. Well, at that time there was only blood sugar estimation. The 3 monthly test, so-called HbA1c, simply did not exist.
Absolutely.
Then we talk today like time in range, which simply did not exist. We talk about continuous glucose monitoring, that simply did not exist. So people were just talking about the blood sugar, examining the blood sugar, and the blood sugar at that time, about 50 years back, had just changed from the Folin-Wood method to the glucose oxidase method, which was more reliable, and that is the only test on which they were depending. With regard to the other kind of monitoring, like microalbuminuria for nephropathy, simply did not exist at that time. So they were using only albumin or blood urea or creatinine kind of test for complication. For retinopathy, the fluorescent induced angiopathy, retinoangiopathy had just started. So there were not many options for monitoring at that time, for either for diabetes or for the diabetes vascular complication. Thank you.
Thank you. Sir, I have another question for you, which is very important because I remember I did one session with you, sir. You spoke about the insulin use then and now. So I remember, sir, Sarita madam, we were together where Professor Vinod Kumar told about the injectables available, and I'll not he put the cart before the horse. Sir, we would like to listen from horse's mouth very, very briefly, sir. Time is a constant about the insulin use then and now.
Well, insulin discovery, not only the insulin discovery has been a epoch-making discovery, but its use of its journey during last 50 years has been equally exciting. How we have improved on insulin use, different preparations of insulin, methods of delivery, we have come a long way. As you know, in the beginning, I remember about 60 years before, when I used to live in Agra, I was a house physician. By that time, I had heard only one person getting insulin, and he was getting insulin through a visit by a local doctor who used to go to his house daily, morning and evening, and inject insulin. That was a regular insulin twice a day. And I never heard anybody during that 1 year, anybody taking insulin either on his own or by a doctor, visiting doctor. So that was the state of affairs. And use of insulin was not so common. Tablets had already come. For example, the sulfonylureas and biguanide, they had come in 50s and 60s, and then so many other came. So there was already less use of insulin in type 2 diabetes, but type 1 diabetes, of course, it was essential. But coming to the different kinds of journeys that we have undertaken in the use of insulin, this early insulin was a very impure insulin. There are a lot of impurities, and it was nicknamed as dirty insulin. And
Absolutely.
this dirty insulin was relatively cheaper, but the purified insulin was not simply available all over the world. They were not available. Later on, they became available in Western countries, but it took time for them to reach our country. And after this, these we were using impure insulin. And I remember when we used to give this insulin to our young people who were neither type 1 diabetes or neither they were type 2 diabetes, but they were J type of diabetes. That is poorly nourished person.
Yeah.
They would not go into the ketosis in spite of absence of insulin, but yet they will not be controlled by oral drugs. So we used to give insulin to them, and these insulin, when we used to give, they were requiring sometimes more than 200 units per day because they had insulin resistance. And
Absolutely.
definition of
Yes,
insulin
sir,
resistance at that
you
time
called it
was,
in a meet you called it KRD, keto resistant
yeah,
diabetes. Yeah.
KRYD,
Yeah.
ketosis resistant young diabetes, and and they were very poor. They could not afford. So this was because of impurities in insulin. They were requiring so much of high dose of insulin. After that, we got, as you know, that we got intermediate acting, then long acting insulin, so that the number of injections could be reduced. And then we started having purified insulin. First the single peak insulin, then the monocomponent, both bovine and from porcine sources came, and then finally in 1983 the human insulin came, semi-synthetic and biosynthetic, which were really being used at lower dosage. Their requirements were not so high. They had lot less of reactions like lipodystrophy or insulin allergy. And then, of course, towards year 2000, we got what is called designer or analog insulin. These analog insulins became very popular, and they are still being used, both short acting and long acting. So this is all about the journey of insulin, and we have come a
Yes,
long
sir.
way.
Thank you very much. Very much. I think
And,
great,
and
great
of
answer.
course,
Sir, I
yeah,
would like
thank
to
you.
ask Sarita Madam two things. Madam, very brief answer. One is about, you remember, Madam, sliding scale? Used to
Yeah.
go by the color. Sir would remember, Vinod Kumar remember, we used to go by the color. Blue this much, blue is nil, yellow is 10, orange is 20, red is 30. I laugh at this situation, madam. You must have gone through the sliding scale. One word of about sliding scale. And madam,
Mhm.
some from your memory and practice, very, 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 very briefly, one instance of something interesting about insulin. Yes, madam.
तो एक कहानी इसके बारे में हम बताना चाहेंगे इंसुलिन के बारे में जो सो कॉल्ड इम्प्योर इंसुलिन या जैसे डॉक्टर विनोद कुमार कह रहे थे I hope everybody is familiar or should be familiar with the story of the first woman. As a woman, I will talk of the first woman.
Yeah.
So I'm sure Leonard Thompson, Teddy Ryder का नाम भी काफी famous है as the first few. अच्छा, the other interesting thing is आपको ये जरूर पता है कि इंसुलिन डिस्कवर किसने की, या जैसे आप कह रहे थे कि डॉक्टर जाते थे लगाने आगरा में, लेकिन वो डॉक्टर का क्या नाम था जिसने पहली बार इंसुलिन का इंजेक्शन दिया? He is also famous, but very few people know. That is
JP
Ed
Bose, JP Bose, JP Bose,
Jaffrey in India में ना,
JP
India में
Bose,
JP Bose,
Calcutta.
JP Bose
यहाँ
from the
पर
Calcutta
India,
School of
I'm saying
Prophet.
internationally it's Ed Jaffrey.
Yeah, Japanese. And madam,
Internationally
the
it's Ed
first
Jaffrey.
patient, since you are the queen, I must tell you, madam, it was Kumudini by JP Bose, who gave it to a type 1 diabetes called Kumudini. And it was a heart painstaking research by one of our colleagues, Mohan. And he went to Calcutta, and there was it was discovered that she is the first lady to good, and it was published in the Indian Medical Gazette. Madam, I like to know that you have been a protagonist of the diabetes in the women. What is the drug used that time for the GDM and the pregnancy diabetes, madam? Just briefly. In your earlier days, madam. Now, though, we are using insulin, we can use metformin. But that time, what was the concept of using managing GDM and pregnancy diabetes, madam? I think we have lost Sarita Bajaj, madam. Are you there? I think madam is lost. So I'll go to the last. Yes, madam is here. Madam, what are the drug used in the GDM and pregnancy diabetes? We will come back. So the last question, Purvi, the last question is about the complications. So we know today that acute complications and the chronic complications. So today we know that we have to combat complications. So I would just like to know from Vinod Kumar sir. So we have got another only couple of minutes. That what was your take on complication that time, both acute and chronic? That's enough, sir. Now we know that we have to monitor and control complications. Very, very agree. And we talk up today. हमारा ये है कि first year of control matters. First year of complication control matters. So what was the concept that time, sir? Very briefly, in about 1.5 minutes, sir.
Okay. Well, the common acute complication was diabetic ketoacidosis or diabetic coma, which is now much less. That is number one. And in the chronic complications, they were slowly rising in magnitude, both microangiopathic and macroangiopathic. By macroangiopathic, I mean retinopathy, neuropathy, nephropathy, and by macrovascular complication, stroke and myocardial infarction. That is, these are slowly rising, but they were not very noticeable in the beginning. It is only over the year that they started becoming more and more common, and they were taken note of. So these are the complications. But I would like to also add that during last 10 to 20 years, some more complications have been added, which are not so much talked about. And these are, for example, dementia in diabetes. Second is periodontitis. Third is sarcopenia. So these are some of the more complications which have been added. And then I think increasingly the doctors are coming across patients with gastroparesis, a very discomforting complication. So these are some of the recent complications which I think our today's doctors must know, because patients do come with a complaint which the patients sometimes the miss at the periphery. So I think these are some more complications I would
Thank you,
like.
sir. Thank you very much. Thank you, Dr. Sarita Bajaj, and thank you, Puri, for giving this opportunity. We have tried to be very brief. We took 35 minutes for the discussion, and I mean, we took. And thank you very much, sir. We'll be having again after 7 days. I don't know, the faculty will be chosen by Purvi. Whoever will choose, we are available, because this is something our passion. We build the future depending on the past. We built our future from the learning from the past. Thank you very much. I thank the viewers and the doctors who have joined, but my thanks to Professor Vinod Kumar, Professor Sarita Bajaj, and our mother organization RSDI for bringing this wonderful program, and the leader of the program, Dr. Purvi Chawla, over the years, many bites. Sarita Madam, thank you very much. Oh, I'm really grateful.
Well, I
Thank
think
you.
your question was very interesting. We should, now that ma'am is back, you can repose that.
I
After
was just
that question,
thinking,
we
madam,
can wind
the
up.
last question, because
Yeah,
it is a very,
yeah,
very, madam, this was a question that very briefly, madam, we have exceeded time, so 60,
yeah.
30 seconds, that how are we treating diabetes, which is in in pregnant mothers, diabetes with pregnancy and GDM that time.
Okay. So, like again, I go back to Elizabeth Hughes, the first woman who took the so-called impurity. She lived for 63 years. She had 4 pregnancies, uncomplicated, and she did not have any complication throughout. So now the management of I think your question is related to management of diabetes in pregnancy.
Yeah.
So we can use any type of insulin. And it doesn't, I mean, what I'm saying is conventional as well as analogs. Not all the analogs, but conventional, you can use any of those insulin. You cannot use all the analogs. Some have
Absolutely.
not been approved as yet. But the crux of the matter is the sugar has to be very tightly controlled during pregnancy. So very frequent monitoring, regular use of insulin as and when required. There is some debate about whether you can use oral agents in pregnancy as well, but for the large part, must remember that it should be insulin and insulin during pregnancy. So good monitoring, good control is the crux of the matter. And then this is in transgenerational. So if we can control glucose during pregnancy, so we prevent children from being macrosomic overweight children and subsequent development of diabetes in the next generation. So
Thank you, madam.
if we are going to thwart the progress of the so-called pandemic, it has to be women right from if they have already known, because marrying late, conceiving late, so they should be tested, they should be counseled if they have diabetes to have good control before conceiving, which is paramount for the future generations to come.
Thank you, madam. You have highlighted very important point that we sometimes say. I wrote a book, madam, that diabetes in women. Professor Vinod Kumar sir, I'll give the book to you. I wrote that diabetes in women is different, difficult, and often dismissed. I think Saida madam has read that book. That micro published that book. Now it's a free
Ashok,
distribution.
I have a small point of historical interest.
Yes,
And I have a name of a patient, I have to see, I don't remember now, who got married at the age of 11. got pregnant at the age of 12 and became diabetic, and she was treated. That was many years before, even before 50 years. I think that lady was in Calcutta. And incidentally, one of the first, if not the first, one of the first girl who received insulin by JP Bose, the name was Kumudini.
Kumudini, correct, sir. Correct. Absolutely correct. So, dear friends, we will all good things up to end, and I have to hand over to Purvi. Now, I must tell you, we are ending in a note about women. Because as Sarita Madam pointed out and Prof. Vinod Kumar pointed out, diabetes in women is important for two things: transgenerational transmission and also breaking the NCDs, because it is believed from the Barker's hypothesis. I will just tell you for the audience that if there is a maternal malnutrition, maternal hyperglycemia, it can manifest with diabetes, high blood pressure, heart disease, obesity, etc. So if you take care of that, you can also break the chain of the NCDs. Dear friends, our time is up, but we had a group discussion, and I'm thankful again to Sarita Madam, and both me and Sarita salute Professor Vinod Kumar, our most senior most colleague as a living legend. And over to Purvi. Purvi, we exceeded time. Purvi, there's a saying in our circle in Pondicherry: the daytime belongs to hospital, etc. Evening time belongs to us. Purvi, me, Sarita, our leader, our living legend, Professor Vinod Kumar. So we have exceeded time. I'll excuse us. Call us next time. Anytime you want us to call, give chance to others, and we'll be there to think about this diabetes 50 years back and today. Thank you very much. Over to Purvi.
Excellent, sir. We had envisaged, we had something in mind for this episode, and I can only tell you that it has just superseded what we also had in mind. It was done so well, and what was shared today was a wealth of knowledge and information. हमारे दोस्त जो लॉग इन करते हैं उनको सभी को बहुत पसंद आया होगा, क्योंकि इतना सारा ज्ञान का खजाना एक साथ खुला नहीं है डायबिटीज के बारे में. पिछले 5 decades or 50 years of diabetes, we have not learned so much even in the books. So thank you, each one of you. You all are living legends for us, and we only learn and get inspired from you. So thank you very much, Dr. Vinod Kumar sir, Dr. Ashok Das sir, and Dr. Sarita Bajaj ma'am, for being there for RSSDI Diabetes Bytes, sharing your thoughts, sharing the evolution of diabetes treatment over the past 50 years and the nature of diabetes itself. I think it was invaluable, completely invaluable. So thank you again on behalf of our National President, Dr. Vasant Kumar sir, Dr. Sanjay Agarwal sir, who is our secretary, and the entire executive committee as well, and the social media Diabetes Bytes team. Thank you so much for being there for us.
Thank you.